Thank you for everybody for coming here. We are going to talk about different projects to see what's going on in one region called MENA region. And we're going to provide some examples of these collaborations that happen between UCSF and some countries in the region, WHO and UNAIDS. And we are looking forward to have you, your brain or your contribution in the following projects that's going to be part of this collaboration between this group and the region. This presentation has three parts. My section is I'm going to provide some backgrounds about the region to see what countries are included, and then I'm going to provide some examples about HIV and sex work and the estimations, and there's some challenges that we have with this specific region as one region in the world to deal with the disease and HIV particularly. Looking at the region, Middle East and North Africa, MENA is a region that is located on the North Africa, and from the east it goes to India, and from the west it goes to Morocco. And we are talking about 22 countries, and it's not very fixed. So somebody may call 2 more countries will add it or less. According to the WHO and UNAIDS, there are some discrepancies. However, this is generally acceptable as a MENA region and Middle East region. So if somebody says MENA or Eastern Mediterranean region, they're talking about this specific particular geographic area in the world. And the particular reason for that, they are Arabic countries, and Iran is also part of this. Morocco is part of this. So to the north is close to the Europe. To the south it's partly close to the African, and from the east it goes to China and India. This is the area and geographic region for that. And the WHO and UNAIDS regional office is located in Egypt, Cairo, and they are coordinating the international activities in the region as a regional office over there. Speaking to region about the disease, still communicable disease is taking 1/3 of the illness, and burden of the disease comes from the communicable disease. It's different from any other region, and it's very unique. And 55% of the total years lost in the region are due to communicable disease. And it's not an unfinished issue for this region, and it's going and going and going to take more lives for the residents for the region. Talking to HIV, it's very specific. This is the only region that the new infection is coming up and rising. And as you can see from other regions in developing countries, these are the World Bank categories, and you can see the MENA is the only one that epidemic is rising. We'll talk about this when we talk about some projects that have some data about this. Speaking to the communicable disease, we should include always emergencies that's happening in the region. It's very surprising that 16 out of the 22 countries in the region now experiencing emergencies. And these are human-built disasters, and also the nature, earthquakes, and all those things that happen also affecting the people too much in the region. 2 of the countries has facing a grade 3, which is the highest grade of emergencies and disasters according to the WHO categories: Syria and Iraq. And Yemen is grade 2 emergency, and 3 others have a priority emergencies. It means they're lacking a lot of things and they need humanitarian assistance generally. So overall, I would say MENA is a very good grocery for disease and disasters. If you want to buy something from this market, it's very unique. Sex work and HIV epidemic in MENA is somehow very unique because of the culture and the main culture of Islamic norms and culture things that's going with the region. The region itself has a very young population, sexually active. 63. It's my calculation using some data or triangulations from other papers. I came up to a number of about 250 million people are sexually active in the region within the range of 15 to 44. And it's included 63% of the total population in the region. And the contribution goes Pakistan with the highest population, Iran, Egypt, and Afghanistan are following based on the population size they have. And speaking to the prevalence of female sex worker by the region, this is a review from published in STI journal, and you can see there is lots of data from other countries that the estimation goes from 0.3% to 7.5% from Latin America according to the person of female sex worker. And in that review, there wasn't any study from MENA. We're talking about this review was published in 2006. Now we have more clue and data on the region. But according to the general prevalence of female sex workers to the world, I think we expected that we have about 100,000 female sex workers distributed in the countries in the region. So it's using the minimum average of 1 per 1,000 female sex workers. This is the number I came up for the sex workers. I start with the sex size estimation because always there's a challenge with the countries in the region that nobody wants to accept that this population are still existing in those countries. No matter if Islam is the main religious things and the norms are very highly acceptable and the population is morally obeying these things, but this is human and they have this issue, and they should accept that, and then if they accept this, and then they will start providing some services and helping those populations to some certain to get better, to improve their health. Talking to the clients of female sex workers, it's also there are good numbers here. So giving the lower global rate of 2%, or 9%, depending on how you define the clients, if they only paid money for sex, or they pay anything like goods or anything else for sex, it's not 2 to 9%. Using the 2%, I think the total number is a good number. We're talking about 3 to 13 million clients of sex workers that are living in the region in different countries. As you can see, this is the overall distribution and pattern. This triangulation or extrapolation also could be when we look at local studies like network scale up to size estimation. We can say in some countries that they come up with some estimates. These estimates are in line with the global estimates, and we have about 2 to 7% of the young people having contact with sex workers in the last year, according to this study, small study in Kerman in Iran. And talking the prevalence of HIV, it's different in the region. So Morocco is now reporting estimating about 2% of female sex workers having HIV. It's 0 to 8%. The confidence was too wide because the sample size was not good enough. Iran, in the first round in 2008, we estimated about less than 5%. But when we're talking about female sex workers who inject drug, the number is so dramatic. It's about 11% have the HIV positive. And it's interesting, other countries like Afghanistan, with all the situations and going on in the field, they also have studies in female sex workers, and the estimation is about 0.2%. The prevalence for HIV is estimated. Where this HIV new cases come from? This is the mode of transmission that Iran and Morocco has done this in 2010, and again, it's different. In Iran, about 70% come from injecting drug use, the new infections, or their sexual partners. And those in red are those belong to female sex workers or clients of female sex workers or partners of the clients of sex workers. As you can see, Morocco is different because it's 40% comes from the sexual act, sexual route, and those things. And Thailand, it's even less than those, and then you can see. So, giving this picture, Iran is estimating about 10,000 new cases every year, and this is the distribution that we have according to this modeling the new infections come from. For the risky behaviors, in Morocco, the clients per week about 4.3 clients per week, and the consistent condom use is about 60%. And speaking to anal sex, it's only 26% they're using consistent condom. In Iran, for the first round of female sex worker, the clients are about 2.3 per week, and the last sexual condom act, the condom use is about 60%. And we're talking about the consistent condom use, it's very low. It's about 1 out of 3 using this condom consistently. In Afghanistan, again, the consistent condom use is very, very low, as close to 10%. So it's obvious where those infections come from. So speaking to challenges, the first one, I think there is no way to estimate very accurately the size estimation. So we came up with different methods to estimate the size of female sex workers. Those in red, those in yellow, they are the methods that applied in some countries in the region, and we have some experience to implementing those things. But speaking to the other methods, we didn't implement, or we didn't involve or look at any studies that doing those methods. Especially the network scale-up method, which is an indirect method to measure the size of estimation, is a method that get very attentions and implemented several methods for network scale-up in Iran to estimate the size, but also we implemented the other methods like multiplier in the new female sex worker studies. Challenging too is how to have access to these groups, which are very hidden and hard to reach. RDS, street walking sampling, convenience sampling, and rapid assessment and response methods have been implemented to recruit or getting those sex workers to the services. However, the convenience sampling is the most used and commonly practiced to recruit the female sex workers. Mapping also involved in some of the projects, but not very systematic time indication sampling. We couldn't find any studies that use this method as a recruitment method. Another challenge is to measure accurately the HIV risk behaviors, and it's underreporting it's a common practice, and it's a challenge for studying the behaviors in a very high stigmatized setting. One thing that have been done is using some methods to correct for the bias, and there are some methods that publish in the BMSA and AIDS and Behavior Journal to capture these biases and adjust the estimates for this bias. For example, when you adjust this underreporting for STI symptoms, the observed prevalence increased from 52% to 82%, 30% higher. And it's significant because when we are going to report this is a huge significant, and we should take care of this. Speaking to challenge 4, it's early loss to follow-up even with those who are linked to services. And this is a study that was done in 2012, and it's in capital city, it's in Tehran. And among the 100 and 1,500 cases of HIV who are linked to the service, 70% lost to follow-up in the first after the first visit, and 17% more are lost in the 6 months. So we are talking about the center in the capital setting, having all the resources, and this is the feature we see. Talking to the mortality is also very high according to what we estimated. The mortality is 7 per 100 person years, and in developing countries, on average, the mortality of HIV cases is about 5.5% per person per 100 person year. And we see a dramatic difference between men and women according to the follow-up. And we talk about maybe this could be because of the men are mostly injecting drug users and they have so many other issues, and those things make them more prone to get into advanced stages, and the mortality is considerably higher in men than women in this study. Challenge 5 is about talking about the resources and the health workers and researchers with low capacity to do this all, to address these challenges. And maybe this is something we are pushing from our side here to build collaboration, strengthen relationship, build networks of exchanging, visiting scholars or exchanging the researchers between this, and making collaborations between the knowledge and lab and those things. These are some examples of ongoing projects with the MENA region that we are involved as a group, and the list is about the female sex workers second round that has been that is an implemented ongoing project in 20 sites, 13 cities, and including 1,500 female sex workers in Iran. There is also a grant under review in CAPS about the UFO sister study to design and conduct a study of cohorts of injecting drug users in Iran to study what is the effect of opium substrate therapy and the other combinations on HIV and HCV risk. There is also an ongoing project to assess the needleless syringe program to see what is the optimum number of syringes to be distributed and what is the individual level of the coverage of the syringes to see what is the effect on HIV and what is the optimum interventions to get maximum benefits from NSP programs in Iran. There is a 5-year HIV surveillance program submitted to Global Fund for Afghanistan, and it's under review. So we are hoping to get this grant. It's a huge project for the next 5 years, and maybe it could potentially another field of collaboration with the region. And yesterday there was an interview, we had an interview, we shortlisted for a grant from Menorah. It's an institute working on harm reduction program, and they're asking for doing an operational study among MSM who use drug in 5 countries in the region to make a policy report to see what's the gap for services for this specific group and what is the way moving forward to improve the services for this population. Speaking to population size estimations in another country in the region, Georgia, this is a project funded by Global Fund, and the study was completed. Mapping and behavior surveys of street children in Iran is another grant funded by UNICEF, and the protocol is on the way and it's going to be implemented very soon. Test and treatment cascade analysis, a treatment also a kind of activity that we're going to be involved. And Rachel is going to talk about another project with Lebanon about transgender women that it's coming up for. She's going to present in a few minutes. There are some institutes, if you want to work with the region, there are some specific institutes that we have a long collaboration with them. Knowledge Hub for HIV surveillance. Al Rayan Qatar Institute has a very good standing and team to do this research. INCAS Knowledge Hub. They are mostly related to clinical-based science, HIV in Tehran. Menorah is another institute for harm reduction. You can contribute or start collaboration with them. And international collaborations that help doing these studies are including Global Health Science CAPS Knowledge Hub for HIV surveillance in Zagreb, and also the Center for Eastern Mediterranean Studies in Chicago. They also have some studies that work with the region, and especially, and also San Francisco Department of Public Health, who are involved in the UNICEF study, and Willie and all the crew are in this team. So if you want to locate for one good quality institute that you want to work, maybe looking at the WHO Collaboration Centers database is a good way to go. And there is a link here. You can look for the countries. There are 47 collaboration centers for WHO in the region. About 30% of them located in Iran, but in other countries there are also that you can start working. And if you want to specific working on one area, for example, HIV, there are 5 centers in 5 different countries that working on this area, and it's a way to go. This is my conclusion. I think we are not going to stop. It's a hard, challenging region to do study or to address this epidemic, but we are not together. I think we can do something to improve some lives and save some lives in this region that they actually deserve it. And the last thing I want to announce is in fall we're going to have a symposium especially for HIV in MENA, and watch out for this announcement, and more is coming soon about this. Thank you.